I'm going to talk to you today about trauma lessons. There's a lot of different ways that a trauma can present to the emergency department. Sometimes trauma presents with a family member rushing in, asking for help getting a loved one out of a car. Sometimes a trauma presents with the person actually walking themselves into the emergency department. When I was in downtown Atlanta, Georgia, sometimes trauma's presented with a person dropping off their friend on the ground outside of the ambulance bay for people to find. But most commonly, a trauma will present with a call and a report from EMS. And it goes something like this.
23 en route to your facility with a 75-year-old male who was a restrained passenger in a motor vehicle collision. Their car was sideswiped going about 50 miles per hour. Airbags did deploy and there was positive loss of consciousness. On arrival, patient's GCS was 12. He was complaining of headache, neck pain, chest pain, and also had an arm deformity. Vital signs are 110/68. Heart rate is 130. Patient has a face mask of 6 liters and is 95%. He has an 18 gauge in the left AC and we're 5 minutes out. Any questions?
Wow, that was the best EMS report I've ever heard. They're not usually that great, but that's kind of the idea of what it would be like. So when that call comes in, usually the charge nurse will field the call and then will designate the level of trauma. This very busy slide is kind of intense and detailed, but I'll sum up. These are criteria that determine whether something is a trauma 1 or a trauma 2. So a trauma 2, easier way to think about it for those in the crowd that aren't familiar with the trauma, means that it's super serious. Trauma 2 is super serious. Or as my kids say, it's low-key serious. And a trauma 1 is super duper serious, or as my kids say, high-key serious. Another way to think about trauma 1 and trauma 2 is that a trauma 2 is potentially threatening to life or limb, and a trauma 1 is immediately threatening to life or limb. And so why does this matter? This matters because depending on the severity of the case coming in, it determines the number of resources that they need to have immediately on hand to take best care of the patient. In other words, the more critical patient, the greater the number of resources immediately available. This is an example of what the trauma room might look like. So our EMS call met criteria for a trauma 1 or a most serious trauma coming in. So players that might be involved in this would be an ED provider, respiratory therapy, critical care tech, secondary nurse, trauma nurse, radiology, trauma surgeon, scribe, pharmacy, security, OR, charge nurse, social worker, EMS, sometimes police. A lot of people taking care of that patient, right? A lot of players. We don't have time to go into what every person does in that trauma room, but what I want you to know is that every person in that room has a highly specialized role and that they're excellent at that role. So what I would like to show you now is a trauma that happened in 2023 at Utah Valley Hospital. And while you're watching this short clip, I want you to make some observations about what you see happening in the trauma.
2 victims, 1 victim inside the truck. Another victim on the first floor was pinned by that truck. He was taken to the hospital, then flown to Utah Valley from there.
All that we knew is we were activated as a trauma 1 and that we had a patient who had been struck by a vehicle inside of his apartment. As soon as Dodge arrived, we were very concerned that he was actively bleeding to death.
His blood pressure was low, he was tachycardic, and they had already intervened to try to allow air or blood out of his chest because they didn't have good respiratory sounds.
All of our next steps were to help reduce the likelihood that he would die by giving him blood and by getting aggressive hemorrhage control. As we were going through all of these steps, someone felt that he had lost his pulse, and we thought his heart had stopped. So he received CPR for about 30 seconds until we reassessed and found a pulse. We ultrasounded his abdomen to look for fluid, either around his heart or in the belly, and found a large amount of fluid in the abdomen, consistent with bleeding inside of his abdomen. And so we now knew the path we were on. He had to go to the operating room. He was bleeding from something internally, and we were going to find it. Immediately found 3 liters of blood that came gushing out of his abdomen. We packed surgical sponges in all 4 quadrants of his abdomen. That slowed the bleeding down. We took him to the CAT scanner, and that's where we discovered his other injuries, which included mostly orthopedic pelvic fractures that would need surgery at a later date. 4 or 5 days later, we took him off the ventilator. That's the first time that Dodge ever found out what had happened to him.
From kind of being right on that edge of death and hanging on by his fingernails, I think he will probably make pretty much a full recovery. The system worked perfectly as designed from all the way before he arrived at the hospital and through the hospital.
It's a team sport. None of it is done alone.
What a great sentence. It's a team sport, none of it's done alone. I'll share some of my observations from that example. So in the trauma room, there's near constant communication. The communication is closed loop and it is valued. Everyone's voice has the same value in the trauma room. There's a protocolized evaluation, ABCDE, airway, breathing, circulation, disability, exposure. It is done the same way every time, and it's done that way so that things don't get missed. You don't ever skip steps. Sometimes things are done in concert, but you don't move on, and that's how we decrease the amount of times that we miss things. There's excellence in respective roles. So everyone in that video, I know, and everyone in that video is excellent at what they do. And they're excellent at what they do before the trauma arrives. They have prepared. Simultaneous and synergistic care. Did you notice how many things were kind of happening at the same time? It may look chaotic to the outside observer, but that things happening in concert and simultaneously are what allow our patients to have a good outcome in the trauma room. Something, I love that Chandler mentioned this in the OR. In the trauma setting, there's also a debrief, and you didn't get to see that in the video, but I want to touch on that. So after a trauma, there'll be a debrief where all the players take time to go through what went well, what didn't go so well or improvements could be made, and how we feel about what happened. And when that is done, an important part, I think, to note about the way that works is it's done without judgment or blame, but for learning and for improvement. So a trauma runs so efficiently because the stakes are high and it's essential for good outcomes. While very few of us in this room are ever going to be in a trauma situation, you're not going to be taking care of someone pinned under a truck and hanging on by their fingernails, as Stephen said, right? But I think there are some takeaways from what happens in the trauma room that we can apply to our practices so that we can have similar outcomes. So the first is the notion that good outcomes don't happen by chance. One of the first conversations I had with Dr. John Edwards when I met him was he was talking about what he does as a neurosurgeon. And he talked about, and he used the phrase, I'm perfecting my craft, right? And I think that's something that we can all be doing and all thinking about, having that level of excellence and perfecting our craft, because when we are excellent in our respective roles, our patients benefit. Have clear roles and value the roles. I think the valuing the roles is what I want to touch on. In the trauma room, people are not looking over everyone else's shoulder, making sure that they're doing what they should be doing. There's trust that every member of the team is highly capable and is doing their best and taking care of the patients. So like in a trauma, using that ABCDE systematic approach for evaluation, I think even when our jobs are not the same, like life and death situations often as they are in a trauma room, having that systematic process approach to how it could be maybe the patient evaluation, but maybe it's just office processes, right? But things that are done the same way every time allow us to have the best outcomes and miss the least number of things. Strengthen relationships for better communications. In the trauma room, I think there is open and easy communication, that people aren't hesitant to share what they're thinking. And a lot happens in a short period of time because people are communicating and know what the left hand knows what the right hand is doing, right? Without having to be all up in their work. And so I think we can also consider implementing a debrief in our own practices like we do in the operating room and the trauma room. Ted Lasso / Walt Whitman say, be curious, not judgmental. So in a trauma situation, the stakes are really high. And I think that drives motivation to be excellent. Do we miss the opportunities in our practices where the stakes maybe aren't so high to be getting that next level of excellence? At Summit, we have an M&M meeting every month. And this is done without ego. It's just kind of like, this is what happened. Everyone shares their thoughts. And we go away with the understanding and I think goals of how can we avoid that in the future, right? And so that allows us to recognize ways that we can improve. Lastly, I think working in medicine is very hard emotionally. Traumas can be really tough, and I think everyone who's been in the emergency room for a period of time has very specific situations where they can remember the whole story and recount every bit of it, the way people looked at you, where you were standing in the hall, things that were said, right? And so a debrief allows you in your practices to share how you're feeling emotionally about what has happened. And so having those relationships and sharing those thoughts allows us to be able to practice another day and to go, maybe to not feel so burnt out. And so let's look for ways in our lives, I think, to support our team members and to recognize there's some times where team members would come up to me and say, how are you doing? That was hard, right? And so you don't have to necessarily wait for someone to come up to you. You have the opportunity to reach out to them. So I challenge all of us to look for some of these pearls or principles that you see in the trauma room and apply it to your practices for the benefit of your patients. Thank you.